Okay, so I've been tasked with a talk about C5 role or complement inhibitor role of C5 inhibition in paroxysmal nocturnal hemoglobinuria. Okay, so the first time I heard about it was in my fellowship actually in 2009, and it's really fascinating the pathophysiology of the disease itself. Paroxysmal nocturnal hemoglobinuria, the name is from the original description where people or the patients would end up early in the morning seeing red urine or dark urine because of the hemolysis that happened more frequently at night. But that hemolysis continues throughout the day. So the name was really more of a description of the patients rather than being the disease itself. What was fascinating and really fun to know was the pathophysiology and how we develop medication to treat it through its pathophysiology. So the first case I'm presenting is a 43-year-old woman. She's actually with us at the moment treating our center. She was referred for anemia and found to have elevated total bilirubin with elevated LDH. Her DAT was negative, and with no previous history of thrombosis. Her PNH testing, which I will come later on to, was positive, and she was diagnosed with that. She was started on eculizumab, and very more recently, we switched her to revelizumab, and we'll go through those therapies in the next few slides. The second patient is a bit older, and maybe Confessor knows this patient before, but I saw him 10 years ago. He was actually a young male, 25-year-old, who was even before that time diagnosed with unprovoked thrombosis. And at that point, later on, he did develop some hemolysis. His workup turned out to be had PNH. He was started by 2012 when I was there. He was already in eculizumab. We had some logistic issues, and was very interesting in him that if we delayed his dosing by 2-3 days, he would present to ER with massive hemolysis, acute renal impairment with creatinines in the 300s. You end up supporting him with fluids, sometimes transfusions. He was maintained on warfarin anticoagulation for long periods of time. Eventually, he had a stem cell transplant at King Faisal Specialist Hospital, Riyadh, and in fact was cured after that. I believe he's still alive as well. So it's a acquired genetic mutation in pluripotent hematopoietic cells, where you actually, the gene responsible for that is the PIGA gene. It's located on the X chromosome. You lose the synthesis of the GPI anchoring proteins, and these are anchoring proteins on the surface of red cells that hold proteins, for example, CD55 or CD59, which are responsible for protecting the red cells from complement activation. It's not here on this figure, but I remember the figure where it's like an inverted J shape, and basically whenever the complement is coming, it prevents it from attaching to the red cell surface and activation. Not only that, but CD5 also protects accumulation of CD or complement 3 on RBC surfaces and extravascular hemolysis. So those are the two, are really what happens in the pathophysiology of PNH. Now, it's really important, but I want to highlight on this on this figure here. Complement has 3 pathways, as you guys know: lecithin pathway, classic pathway, alternative pathway, and all 3 pathways eventually go to activate or cleave C3, which on its own produces C3A, which is an anaphylatoxin, but also 3B, which can amplify the complement pathway and convert C5 into C5A and C5B. C5b is the one really responsible for intravascular hemolysis and attachment to red cells, which is prevented by CD59, whereas the C3 accumulation of red cells is prevented by CD55. Now, some of the targeted, so these two, CD55, 59, are the ones used for diagnosing PNH patients. Not only that, you see factor B and factor D. These are targets for therapy. I'll just briefly touch on that. We've also, the C5a accumulation sometimes causes a pro-inflammatory process. So through this normal pathway, we'll go through what happens to these patients who develop hemolysis, our PNH patients. So main complaint, or most of the patients, 80% of them will have hemolysis leading to anemia and fatigue. So those are the common symptoms. Intravascular hemolysis or releases hemoglobin or free hemoglobin inside the vessels, which is a scavenger of nitric oxide, and that will cause vasospasm, affect also smooth muscles, and that will lead to dysphagia, sometimes pulmonary hypertension, dyspnea also. But pulmonary hypertension and dyspnea can also be a consequence of thrombosis, and thrombosis happens through the nitric oxide scavenger pathway, but also there is the pro-inflammatory from C5a causing vessel wall or endothelial injuries also in these cells. So it's a multifactorial thing that happens, which explains all the manifestations of the PNH patients. So if left untreated, PNH can lead to nitric oxide depletion, vasoconstriction, smooth muscle dystonia, and subsequent complications that can contribute to impaired quality of life. Not only that, before the era of C5 inhibitors, significant decrease in life expectancy was proven. Up to 35% of patients would be dead by 6 years from diagnosis. It is a rare disease. Different populations have different references, so it can range between 1 to 10 cases per million populations. It can be diagnosed at any age, but median age is usually early 30s. There are also female cases diagnosed with PNH, and that's secondary to lionization, which is selective inhibition of one of the X chromosomes. It's a progressive disease. Uncontrolled complement activation underlies the morbidities and early mortality in PNH cases. So how does thrombosis and end organ damage occur in PNH? As I have showed you, so C5a will be the one responsible for the pro-inflammatory, so it will activate leukocytes, cause endothelial cell activation leading to endothelial cell damage, release of tissue factors, cytokine release. Also platelet activation will cause fibrinogen cleavage, platelet aggregations. The C5b will cause lysis of red cell, release of free hemoglobin, and increasing LDH, causing scavenging of nitric oxide, leading to end organ damage, small muscle dystonia, and thrombosis. So LDH is an important clinical marker. In general, we hematologists regard it as one of the first or the most sensitive marker for hemolysis, and that's true in intravascular hemolysis, which we see in PNH patients. Not only that, so what are the predictors of thrombosis in these patients? So having chest pain or abdominal pain or dyspnea increases your chances of having an underlying thrombosis, but that combined with an elevated, LDH, which we define as more than 1.5 upper limit of normal, that really increases significantly your chances of developing thrombosis, and that's what's shown in this trial. Thrombosis risk is 7 times greater in patients with just elevated LDH, and you don't need it very high, just above 1.5 upper limit of normal. As you can see, it increases more by 7 times. Which patients should we suspect and we screen for paroxysmal nocturnal hemoglobinuria? So it's a night mnemonic catch. So those who have a Coombs negative hemolysis or have hemoglobinuria or hemosideриnuria, unprovoked thrombosis. I have to say, I've been screening for a couple of years now. I haven't thrombotic patients. We haven't seen a patient with PNH yet, but that's still one of the presentations that can happen. Patients with aplastic anemia or patients with cytopenias, especially MDS, usually they do carry a very small clone of PNH cells, 1 to 2% usually, but sometimes these patients may actually be PNH patients who have developed bone marrow failure syndrome. And according to their presentation, some authorities would divide them into different categories. So PNH with hemolysis, PNH with thrombosis, subclinical PNH patients, which are basically having very slight elevation LDH, but no really anemia, no other manifestations, and PNH with bone marrow failure, basically those patients with PNH and aplastic anemia or myelodysplastic features. We will be really concerned with the PNH patients with hemolysis. So ravulizumab indicated for the treatment of adult and pediatric patients with paroxysmal nocturnal hemoglobinuria. So it was built on the backbone of eculizumab, which has been the treatment for ravulizumab for a very long time. It inhibits the C5, complement 5. But ravulizumab have an increased affinity to factor 5. By that, it has a long, by that it's more complete and sustained C5 inhibition, as well as pH-dependent release of factor 5, so it improves its clearance from the system. And the FC region has been modified to have a higher affinity for neonatal FC receptor, and by that increasing its duration in the circulation. And that's why the duration of, or the interval between the doses of ravulizumab is actually 2 months or 8 weeks. So eculizumab is again intravenous. Both of them are actually intravenous injections. Eculizumab is given after the loading weeks or after the loading dose every 2 weeks, whereas ravulizumab is given every 8 weeks. So this is really different in administration and also convenience for patients as well. So the other big difference, fixed dosing for eculizumab, where this is a bit more tailored to patients' weight. So that's a weight-based, gives you the leisure of being more specific to patients. The long-term elimination half-life of intravenous Ultromis allows adult patients to receive infusions at 8-week dosing intervals, and that was really engineered in the backbone of the antibody. So ravulizumab was studied in 2 randomized controlled trials, nicely called 301 and 302 trials. The 301 basically were naive patients of PNH, so had never received any treatment, and they were either randomized to receive eculizumab or ravulizumab for 26 weeks, and after that all of them continued on ravulizumab. Whereas the 302 trial, basically these patients were all PNH patients who were on eculizumab. After a 4-week observational period, half of them continued on eculizumab, where the other half were randomized to ravulizumab, and after 26 weeks, all of them continued on the extension period on ravulizumab. So collectively on both of those data, LDH significantly was more lower in the ravulizumab arm, as well transfusion avoidance or transfusion independency. Hemoglobins were even better with the ravulizumab arm, definitely. Breakthrough bleeds also were better, and I'll touch a bit on that more. So breakthrough bleeds were also better in the ravulizumab arm compared to the eculizumab arm. LDH also better. So on all parameters, either better or same results. It was a non-inferiority trial, and it did meet its endpoints. So that led to the approval of the medications for that. Now, why do we get breakthrough bleeds? Earlier on, I showed you the figure where the pathophysiology of the disease is. So we do inhibit C5, but we do not do anything with C3. And C3 will accumulate on the red cell surfaces and cause extravascular hemolysis. So that could be a reason. Another reason, which is more common with eculizumab, is some patients may do not tolerate the 14 days, the 2-week duration. They may hemolyze just before that, so you just need to decrease the duration in those patients. So that's the reasons for the breakthrough bleeds. Looking at the free C5 levels, if you look at the, just because the way ravulizumab works, you will find sustained lower levels of C5 compared to the eculizumab, where there's hectic and where there are occasions where C5 is higher, which may contribute to breakthrough bleeds through intravascular hemolysis. So there is a more sustained C5 inhibition with ravulizumab. LDH is throughout whether it was the randomized first 26 weeks or the extended period, was maintained below expected levels actually with ravulizumab. And in the breakthrough bleeds, none of the bleeds in the ravulizumab arm was due to increase in C5 levels. As you can see, they maintained it at 0 levels basically. So that was really reassuring that C5 was, efficacy-wise, was really inhibited with the ravulizumab. The commonest side effects, which we have seen actually, are a headache and upper respiratory tract infections. They're non-severe, so it's easily managed. Probably in the trials, the most severe reactions were just fever. Those were the grade 3 or 4. But apart from that, both of them were tolerated very well and comparable. So, Ultrameds built on foundation of eculizumab is designed to deliver long-acting treatment, has been studied in the largest clinical trial program of adult patients with PNH to date, is indicated for the treatment for adult and pediatric patients 1 month of age and older with PNH. It is a weight-based regimen and was developed to have long terminal elimination, half-life, and clearance, allowing for longer dosing intervals, 4 to 8 weeks. We used 8 weeks for PNH treatment. Ravulizumab or eculizumab has been studied for over 2,000 and 62,300 patient years, respectively. There are other medications. I didn't put a slide on it because we were just discussing the C5 inhibition role in PNH. But you have approved, so the FDA approved, pegcetacoplan, which inhibits actually C3. And the only difference in the trials of that to compare it to C5 inhibitors, it has never been used in naive patients. In fact, it was used on patients who were already on a C5 inhibitor, although probably theoretically you could use it from the beginning. I look at it that would be an add-on medication if you have breakthroughs and they have difficulties unmanaged, or if you have persistently lower hemoglobins or hemolysis ongoing. There are other unapproved medications, tablets, so those are off-label use basically, but all of you know the last ASH late-breaking abstract, iptacopan, the oral medication, or danicopan, which may be coming soon also. Both are oral medications. One of them is given, the first one is given twice daily, the other one 3 times a day. That's a bit inconvenience and will cause definitely compliance issues with the patients. Danicopan is actually studied as an add-on to a C5 inhibitor, ravulizumab probably, and that would be really nice in patients who have breakthrough bleeds. That would be, because you're going to inhibit both, pegcetacoplan inhibits C3, iptacopan actually inhibits factor B, and danicopan inhibits factor D. So all working on the C3 esterase pathways. I think that's what I have. And lastly, all of these complement inhibitors predispose especially to Neisseria meningitidis infections, so you have to vaccinate your patients at least two weeks prior to starting. And if you are in a hurry or the patient wouldn't tolerate waiting for that period, then you should vaccinate him and start him on ciprofloxacin twice daily until the 2 weeks are there and he's have gained immunity against the bacteria. Again, vaccination is not 100% protection. Educating your patients regarding signs of fever and signs of meningitis and seeking early medical care for fever is really, really important. And I thank you for your attention, and thank you.